TGIF, everybody. It's Shannon from the Arthritis Patient Advisory Board at Arthritis Research Canada. And this morning I have with me Dr. Deborah Marshall, who is a Senior Research Scientist at Health Services Research and Health Economist, first coffee I'm still on, at Arthritis Research Canada. Professor in the Department of Community Health Sciences at the University of Calgary, and the Arthur J.E. Child Chair in Rheumatology in Calgary. Thank you for joining us today.
Thank you for having me here.
Can you tell everybody what brings you here? Because I know, not every rheumatologist goes to every conference, so.
Absolutely, and this is the Canadian Rheumatology Association meeting, and I'm a health services researcher and health economist. I know that's a big mouthful on a Friday morning before your first coffee, but basically I study the health system and look at, how do we get value for money in the care? So it absolutely has to be effective, but are we spending our money wisely? Because we only have so many resources. So that's kind of the research.
And that's what both sides of the table want,
Absolutely.
Well, all three sides, the government, the caregivers, and patients.
Yep.
Yeah.
And I think there are opportunities, to provide better care, and we always have to be striving for that. And we can also provide cost-effective care. So
where the resources can then be, shifted to more care.
There you go. See, you're a health economist too.
Thank you. And so, what have you been working on most recently?
Well, we have lots of things cooking. I think the most exciting thing we're very pleased about was, and this is different from what I think we're going to talk about, but was our recent award looking at juvenile idiopathic arthritis. And one of the messages there is that I think people often think arthritis is something that occurs as you age, but in fact there are children out there who have arthritis, and it's crippling and devastating and it has long-term consequences. So we were very excited about winning a CIHR and Ziekenfondsrad grant to study juvenile idiopathic arthritis. It's got a lot of personalized medicine and genomics built into it, and of course health economics, to look at what is the socioeconomic impact of juvenile idiopathic arthritis. How do we measure that? How do we quantify it? How does it impact people's lives? So it's the patients, which in this case are children, and their families and their networks. So that was also a CIHR Genome Canada grant as well. So we're super pumped about that, and that's what we're launching right now.
I think patients are very excited about the science behind what is coming up for them, what the possibilities are for changes in treatment and reasons why they have their disease, and because that's going to impact them down the road, if not them immediately now, arthritis patients in the future.
Absolutely, and especially I think in children, the idea of looking at when do you start treatment, and then when could you potentially taper or potentially stop treatment. So these are really hot research items right now, and we'll have the opportunity to look at that and do some in-depth work around what is the impact on people's quality of life, and also the broader socioeconomic impacts with respect to private dollars that are spent for things that aren't covered by our health system as well.
Yes, so, that are needed in the full model of care, the full spectrum.
Absolutely, and also presenteeism and absenteeism, or in this case with children, absence from school. What kind of long-term impact does that have? So that's the kind of thing we're interested in exploring and unveiling, unraveling, I guess, more. So that's our, I think, the thing we're launching and excited to get going right now. But I think we were going to talk about models of care. So
segue into that, because that's something that I've also participated in as being on the Consumer Coalition at the Arthritis Alliance Canada. So it's been very, very exciting to see what's happening with the work that's being done there by so many people.
Yeah, and I think that's the exciting part. And actually, one of the reasons why I think it is nice to be here and have collaboration. So we have a joint bridging project between the CRA, the Arthritis, so the Canadian Rheumatology Association, the Arthritis Alliance of Canada, CIHR, because our doctoral student who's working on this also won a CIHR Health System Impact Award, so that was another great thing.
Fantastic.
And the CATCH, so the Canadian Early Arthritis Cohort. So that is a coalition and partnership between all of us to look at models of care. And you might say, well, what the heck is a model of care? And there's lots of different definitions, and it's kind of confusing. But in general, it's really about a process or the steps in delivery of health services for patients who, along the continuum of care. So as they progress through their journey with their disease, and looking at what is the best practice for those deliveries. That's essentially, what the model of care.
And in turn, getting the best bang for the buck and not wasting.
I like how you keep bringing in the health economics. Thank you. Yes.
That's what it does, and it's all, it's more effective treatment for the best amount of money, the dollar spent.
There you go.
And that's what patients want too. And I know with juvenile idiopathic arthritis, it's even for adults that have arthritis. I mean, we're strong, we can take it, but when we see a child that has this type of pain that we have, it's difficult for us to even, adults with arthritis, to even fathom them going through. So,
yes,
having a model of care in place, that starts when they're children, and getting through that process and adopting it as we go. I'm sure it'll be adapted at some, as the system changes, hopefully, and get better.
Right. We hope.
Yes.
So with this, we've done and when I say we, it's the arthritis community. And I think one of the things that's exciting about arthritis is I think we do well at trying to engage our partners and patients like yourself in the process. And we can always do better, but I think we really do try to do that. So through the Arthritis Alliance, we have developed a pan-Canadian model of care for inflammatory arthritis. And I was talking about this yesterday at the CRA in the national updates. So we were giving the situation on this particular project. And the AAC, in partnership, has developed this whole package, really, of tools. So there's that pan-Canadian model of care, which diagrams out the steps in the model of care. There's what we call a master worksheet, which kind of gives you, well, what are the criteria? What defines a model of care, other than that broad thing I just said? And then, there's a toolkit around the care path for inflammatory arthritis. There's a measurement framework, because these things are all nice, but you have to be able to measure it somehow, right? Putting that health economist hat back on, you've got to measure the stuff.
Those dollars to keep the work going.
Well, we have to know if we're doing a good job or not. And then you need the performance indicators, the measures to figure out, well, how do we quantify this and report back? And then we've also developed, as you know, an infographic for patients around the models of care. I think you have it there to flash at the camera. There's the key elements of the model of care, and I think you have then underneath the resources and where.
And then there's resources that we've assembled, and these are all available online for anybody to access. And these are also available if you want to take a copy to your rheumatologist in case they don't know about it.
There you go.
Because these are resources that the patient partners have vetted, and they're reliable resources that your physician doesn't have to worry about you being going to see Dr. Google, and that the information that you're getting is correct, and updated regularly. So patient resource, inflammatory arthritis model of care resources, and the key elements of the model of care.
There we go. Thank you. All in this. 1 page, 2 sides. So we did an update about this collaborative project, and basically we're working through the qualitative research and the quantitative research in partnership. We're using the CATCH sites to study, to look at, what have they done in terms of their model of care, and then we're going to measure the outcomes for the patients in that model of care and do some analysis to say, well, what defines a really good model of care and what association does it have with outcomes? And so the idea is really to use this information so we can have a sustainability of models of care and promote the uptake of these models of care across the country and broader too, but across our country, because it's not like there are these models of care everywhere, and there is evidence to suggest that they help improve.
What's the timeline? I'm sure, Joe Q. Arthritis,
Yes.
that's not familiar with how research works and how these things get implemented, what's the timeline for something to be implemented and to be measured, for example, and to get some results and find out how it's doing?
Well, on a macro scale, years. These things don't happen overnight, unfortunately. But this particular project, for example, will essentially take 1.5 years in total, and we hope to be wrapping up by the end of this year and have some communications out early 2020.
Which is fairly short order.
Yes, well, we're really fortunate because we're partnering with CATCH. So we have sites that are already in place, and 8 of the CATCH sites are participating in our study, and we've completed 15 interviews with them.
So it's starting, it's coming.
It's coming, stay tuned. And on Saturday, which is tomorrow, today's Friday, we're doing a workshop at 8 a.m. Around this project. I'm not able to join, but my PhD student Elena Lopatina, who's working on this, and plus Dr. Carter Thorne and Diane Mosier, who are all members of the Arthritis Alliance of Canada working group on this Models of Care project. So we'll have an hour there to be able to talk about the details. So I hope you can join us. I guess you, since you're here.
Excuse me.
So what I did want to also tell you is we have a specific, so now that we have this measurement framework around models of care, and the first step in the models of care is identifying a patient who has disease, then getting them referred, potentially suspected disease, referring them to a specialist so they can be diagnosed, and then managing the patient if in fact they have the disease, and then thinking about models with shared care potentially to manage. So we have a grant in Alberta, which we've developed these national indicators, these measures, and in Alberta and other provinces, but I have the Alberta numbers on hand, we had a partnership grant through Alberta Innovates, and we've been working very hard to get the clinic data and link it to the administrative to measure how are we doing in these steps of the models of care. And my message is we have work to do. There's room for improvement. There are gaps that we need to fill and to do better. So, for example, in that first step in the referral process, the wait time for patients with RA, so we looked at osteoarthritis and rheumatoid arthritis, but the rheumatoid arthritis example, the wait time between the referral and the rheumatologist visit is a median of 128 days.
It's a long time if you're in pain.
And our benchmark, to that point, you are correct, is 28 days. So only 20% of patients are meeting that benchmark. So we need to do better. Like there's an opportunity for improvement, which is why we are looking at that intake process.
I was in a rapid access program in BC, but it was still 3 months. That was the rapid.
Right.
So if it gets down to a month, I probably wouldn't have ended up in the state I was in by the time the 3 months was over. Yeah.
And it's really important
to
get to, I hate to use the cliche, but the right place at the right time.
Correct.
So that's one.
Yeah.
So there's that initial referral. Room for improvement.
Yes.
2 is when you get from your visit from the rheumatologist, within the first year. Okay, so how many people are getting to see the rheumatologist in the first year of diagnosis? And for this, we're doing about 70% of patients that we know about. So these are patients who are identified through administrative data as having RA, and we're measuring these metrics. Okay, so you do have to interpret it in that context. A third measure is what percentage of rheumatoid arthritis patients are getting treated with DMARDs. Any guesses? What percentage?
It's probably going to be lower than it should be.
Yes,
what I'm guessing.
Correct. So sadly, we're in at about 40%.
Wow.
So room for improvement.
Well, yes, because I would imagine that delayed access to the DMARDs ends up costing more dollars down the road to the system.
Yes.
Catching
so that's
on.
that big perspective. Yes,
Yeah,
exactly.
well, it does, and those are our dollars as well. You know, the taxpayers' dollars that, you know, you don't know what that domino effect is of delayed treatment. Really, you could never know.
I can't say it any better. Thank you. And then the last tidbit here is that once they're under the care of a rheumatologist, so when you get to the specialist, about 80% are being seen in yearly follow-up. So that's good. You know, I mean, you could still say there's always room for improvement.
After a certain
but
amount of
still,
time, is it? Because
once they're diagnosed and they're under the care of a rheumatologist, then in follow-up, like the idea is that people would be seen in follow-up within a year thereafter.
Okay.
So 80% of our patients are being seen. So
Within
that's
a year.
Good.
Do you think if their disease is quite active, that would be a narrower timeline?
So that's an average, absolutely. So if there's any flare or activity,
yeah, or you're trying to get your
shorter.
treatment under control. You know, if there's a
Right.
Yeah.
Absolutely. But as a metric,
Right.
So if we have a measurement framework, we're saying that a minimum people should be seeing in a year
Right.
of follow-up, right? So 80%,
Right.
so this is a general average, right?
Yeah.
Are being seen within that year,
So
which is good.
good.
So yes, we absolutely then have to start digging in
Yeah.
and looking at it. But what this does is give you some key sort of benchmarks or criteria or performance measures to start to be able to understand how our system is working. And then we can monitor and measure over time to see if we're improving.
Right.
So these are some of the things we were presenting. We had 5 or 6 posters here on this work. But I thought it might be nice to kind of share those numbers to give some people idea of how are we doing against those benchmarks and where are there opportunities for improvement.
Yeah, I think it's encouraging to, the patient side of things that there is so much being done. That's why I love coming to CRA, because you can see what's being done in our own country.
Yes.
You know, it's so very inspiring that there are so many people working so hard to make our lives better.
It's a good segue to a question that came in. Why is it so hard to get good pain management in Canada?
Wow, I don't know. That's a
big,
very
huge
broad question. It's a good question because it suggests that it's hard to get pain management. I'm not sure I can directly answer that. With respect to why it might be difficult. I have not studied, pain management clinics per se, but I've certainly heard with colleague discussions and with patients as well that can be challenging. So I don't know what the Canadian scene is on that, but I will say based on the little bit I do know around those clinics, I do think we need to think about that much better. And also, because there's so many reasons people could have pain. I think we need to understand it and get them to the right care.
That's what I was just going to say. What's the cause for the pain? Because if we're talking inflammatory arthritis and we're talking models of care, then maybe there needs to be a model of care for pain management. But there is, with inflammatory arthritis, the cause for the pain could be activity, so you don't necessarily want to mask that pain.
True.
To a degree,
Yeah.
so that you can treat it. So when you know your treatment's working, you don't want it to be hidden by any pain, any drugs that are covering the pain.
Yeah, so I don't know all the procedures and how a pain clinic would do this, but I think the idea is pain can come from a lot of different places, and so it's very important to make sure that somebody is being seen who has pain, so that they can differentially diagnose what the cause of that might be, and then the treatment process would vary depending on what the cause of that pain is, right?
And communication with their specialists is probably really important as well, between the two specialists.
Yeah, or at least to begin with the GP.
Yes.
Then depending on what the cause of that would be, it might be different specialists that they would go to. So it's a bit general.
Yes.
Well, thank you for answering.
Yeah.
I mean, maybe out of your wheelhouse, but still, you do have some knowledge about it and an opinion, to some degree. So.
Yes, and for the individual who asked this question, we can do more research about it and answer it in the comment section. But thank you for coming out.
Thank you so much, Deborah.
All right, thank you. And thank you for the opportunity to share this with you.